lecture is soft tissue tumor with competency number PA 33.3. In this competency, students should be able to classify and describe the etiology, pathogenesis, manifestation, radiologic and morphologic features, and complication and metastasis of the soft tissue tumor. So we'll go with soft tissue tumor. So what are the soft tissues? According to WHO, definition of the soft tissues are, so these are all non-epithelial extraskeletal tissues of the body except reticular endothelial system and the glands. Soft tissues supporting the tissues of the specific organ and the viscera. So the soft tissues are, these are fibrous tissue, adipose tissue, muscle tissue, synovial tissue, blood vessels, and neuroectodermal tissue. This is the definition from WHO. Now, the routine definition, soft tissue tumors and the tumor-like lesions. So, what is meant by soft tissue tumors? These are defined as mesenchymal proliferation that occur in extraskeletal, non-epithelial tissues of the body, excluding the viscera, covering of the brains and the lymphoreticular system. They are classified according to the tissues they recapitulate. Example, muscles, fat, fibrous tissue, vessels, and the nerves. Now, classification of soft tissues. Tumor. Tumor of adipose tissues. Examples, lipoma and liposarcoma. Then, tumor and tumor-like lesions of fibrous tissue. Examples are nodular fasciitis, fibromatosis, superficial fibromatosis, deep fibromatosis, and fibrosarcoma. The next class, fibrohistiocytic tumors, fibrous histiocytoma, dermatofibrosarcoma protuberans, malignant fibrous histiocytoma. Next class, tumors of the skeletal muscles. These are rhabdomyoma, rhabdomyosarcoma. Tumors of the smooth muscles, leiomyoma, smooth muscle tumor of uncertain malignant potential, and leiomyosarcoma. Then vascular tumors includes hemangioma, lymphangioma, hemangioendothelioma, hemangiopericytoma, and angiosarcoma. And next class, peripheral nerve tumors, neurofibroma, schwannoma, granular cell tumors, malignant peripheral nerve sheath tumors, that is MPNST. The next class, tumors of uncertain histiogenesis. It includes synovial sarcoma, alveolar soft part sarcoma, epithelioid sarcoma. Now, next part is pathogenesis of the soft tissue tumor. Cause of the most of the tumor is still unknown. Sarcomas are generally associated with the radiation therapy, chemical burns, heat burns, trauma, exposure to phenoxy herbicides and chlorophenols. Kaposis sarcoma in AIDS patient is related to the viruses and immunocompetent state or the immunocompromised state. Then small minorities associated with genetic syndromes, that is neurofibromatosis type 1, Osler-Weber-Randu syndromes. Now next is location. In location, 40% lower extremity, especially in the thigh, 30% of the tumors in the trunk and retroperitoneum, 20% in the upper extremity, and 10% in head and neck. Now, incidence of the soft tissue tumors. Males are affected more than the females, and incidence is 1.4:1. Now, we'll start first with the tumors of the adipose tissue. And the most common tumor of adipose tissue is lipoma. It is the benign tumor of fat of the adipose tissue, most common tumor in adulthood. Age group is 40 to 50 years, more frequent seen in case of females. Most common sites are subcutaneous tissues in the neck, back, and the shoulder. So this is the photograph showing lipoma, which is soft, mobile, painless lump on the back. Grossly, when it excised externally, it is round to oval, encapsulated. On cut section, it looks like lobulated, yellowish orange, and greasy. This is the microscopic view of the lipoma, showing this tumor is surrounded by thin fibrous capsule. This is the fibrous capsule, and the tumor is composed of lobules of mature adipocyte. These are the mature adipocyte separated by delicate fibrous septae. So these are the delicate fibrous septae. Now, what are the different morphological variants of the lipoma? First, conventional lipoma, which is the most common, then fibrolipoma, angiolipoma, spindle cell lipoma, myelolipoma, pleomorphic lipoma, infiltrating and intramuscular lipoma. Now, next is malignant version of the lipoma is liposarcoma. This is the most common soft tissue sarcoma, next in frequency of malignant fibrous histiocytoma, originating from the primitive mesenchymal cells, that is lipoblast. Age group 50 to 17 years. Location usually deep in the tissue region of the thighs, buttocks, and the retroperitoneum. It get metastasized to the lungs, visceral organs, and the serosal surfaces. Now, liposarcoma. Grossly circumscribed but infiltrative nodular mass 5 centimeter or the more in diameter, usually more than 5 centimeter or the 5 centimeter is diameter. On cut surface, it is yellowish brown, lobulated, firm to hard. This is the microscopic view showing liposarcoma. These are the lipoblasts. Microscopy or the histopathology is the hallmark for the diagnosis. Identification of the variable number of the lipoblast. These are the lipoblast, which may be univacuolated or the multivacuolated. These are the multivacuolated lipoblasts. Now, what are the different types of liposarcoma? It may be well differentiated. The round cell. In round cell, these are round to oval cells with multivacuolated cytoplasms with central hyperchromatic nuclei. The next is pleomorphic. These are highly undifferentiated, anaplastic, bizarre lipoblasts. Large tumor giant cells are seen. Then fourth one is myxoid, small signating lipoblast in myxoid stroma with characteristic branching vascular pattern. So these all are the types of liposarcoma. Now next tumor from the adipose tissues is hypernoma. It is a rare benign adipose tissue tumor composed of brown fat cells with granular or the multivacuolated cytoplasm. Origin is brown fat cell. Generally, two types of the fats are there, brown and the white fat. And this tumor is originating from the brown fat. Young adult, mean age group 38 years. Location, it is on the thigh, trunk, upper extremities, head, and the neck. Histopathologically, polygonal brown fat cells, stromal background, small capillary proliferation. So this is the microscopic view of the hibernoma. These brown arrows, these are the brown arrows, indicate the granular eosinophilic cytoplasm, and the black arrows indicate the vacuolated cytoplasms. Now the next class, fibrous tumors and the tumor-like lesions. These are the reactive pseudosarcomatous proliferation. In definition, These are non-neoplastic lesions that develop in response to some form of the local trauma. It may be physical or the ischemic trauma, or it may be idiopathic. Clinically, it grows suddenly and rapidly, and histopathologically, these are the close mimicker for the sarcomas. For example, nodular fasciitis and the myositis ossificans. Next is fibromatosis. These are the tumor-like lesions of the fibrous tissue. Fibromatosis is tumor-like lesions of the fibrous tissue. It proliferates actively, difficult to differentiate from the sarcoma, generally non-metastasizing lesions, recurs after the surgical excisions. Now, the classification of fibromatosis, it may be infantile or the adult type. Infantile are usually juvenile fibromatosis. Examples are fibrous hematoma of the infancy, fibromatosis coli, and diffuse infantile fibromatosis. In adult type, palmar or the plantar type of fibromatosis, nodular fasciitis, and the keloid. Then palmar fibromatosis, it is usually the painless irregular nodules attached to the overlying skin causing slowly progressive flexion contraction of the fourth and the fifth finger. These are the fourth and the fifth fingers get affected. Next, fibromatosis, desmoid fibromatosis. It may be abdominal or the intra-abdominal. In abdominal, there is a muscular aponeurotic structure of the rectus abdominis muscle. And in case of intra-abdominal, in the root of the small bowel, mesentery. Grossly, this is the gross view, solitary, unencapsulated, gray-white, infiltrating the muscle locally. On cut section, there is a whorled appearance. Then microscopic view of the fibromatosis, uniform looking like these are the fibroblasts, homogeneous and hyalinized bands of the collagen with infrequent mitosis. Now next is nodular fasciitis. Synonyms are the infiltrative or the pseudosarcomatous fasciitis. These are the benign, reactive, and fibroblastic growth. It is most common of the reactive proliferation. Most often occur in adult, location in upper extremity, trunk, and the neck regions. Nodular fasciitis grossly, these are the solitary, well circumscribed nodule in the superficial fascia, extending into the subcutaneous fat and sometimes into the muscles. Now, nodular fasciitis. These are the plump of immature appearing fibroblasts arranged in whorled or S-shaped. This is S-shaped pattern. These cells are spindle to stellate shaped with conspicuous nuclei and prominent nucleoli. Abundant atypical mitotic activities. Stroma is myxoid along with lymphocyte. Extravasated RBCs are also present. These are the extravasated RBCs are also present in nodular fasciitis. Now next is myositis ossificans. It is the benign tumor-like lesion characterized by osteoid and the bone formation in soft tissues. What are the different types? First is traumatic. It may be generalized. In traumatic, usually in young adults, more common in males, often history of trauma and the soft tissue injuries. So this is the photograph showing generalized myositis ossificans. Here, there is a soft to firm masses in the muscles of the neck and the back, grossly unencapsulated, gritty mass replacing the muscle. Now next, this is the microscopic view of the myositis ossificans. There is a central region, loosely arranged fibroblast. At the periphery, there is a osteoid matrix, oven mineralized bone here with trapped skeletal muscles. There is a cellular atypia. Next tumor is a fibrosarcoma. These are usually slow growing tumor and the age group is 40 to 70 years of the age. Location lower extremities in thigh than the knee. In upper extremities, retroperitoneum, head and the neck. More than 25% of the tumors get metastasized and the recurrence is seen in more than 50% of the cases. Now, this is the gross specimen of the fibrosarcoma, which is well circumscribed. Uh, you, it is lobulated foci of the hemorrhage. Here we'll see the hemorrhage and the necrosis. These are the necrotic foci on cut section, fish flesh-like appearance and the soft fish flesh-like appearance and the soft on cut section. This is the microscopy of the fibrosarcoma showing spindle-shaped fibroblast arranged in intersecting fascicles or the herringbone pattern. Poorly differentiated are usually bizarre cells and the frequent mitotic activities are seen in poorly differentiated fibrosarcoma. Now next is fibrohistiocytic tumors. So fibrohistiocytic tumors contain the cellular element resembling both fibroblasts and the histiocytes. That is both component, fibroblasts and the histiocytes. First is benign fibrous histiocytoma, then DFSP, that is dermatofibrosarcoma protuberans, and malignant fibrous histiocytoma. First is dermatofibrosarcoma protuberans, that is DFSP. These are usually low-grade malignant cutaneous tumors disputed to the fibrous histiocytic origin, usually located in the dermis and the subcutis of the trunk. Age group is middle age group adults. Locally, usually these tumors are recurrence, showing the distant metastasis very rare. Now, this is the gross specimen showing the DFSP, which is usually slow growing, nodular or the polypoidal or the plaque like overlying skin is reddish or the bluish. This is the microscopic view of the dermatofibrosarcoma, showing the dermal connecting tumors. Now, this is also the microscopic view of the dermatofibrosarcoma. Here, the uniform spindle cell in radial walls and moderate to high mitotic activity in case of dermatofibrosarcoma. This is also the DFSP showing the storiform pattern. This is storiform or the cartwheel-like appearance in DFS, dermatofibrosarcoma protuberans. Now, next is benign fibrous histiocytoma. Here, in microscopy, there will be the mixture of fibroblast-like cells and the histiocyte-like multinucleated foamy cells or the hemocytin-containing cells. So, this is the benign fibrous histiocytoma. Next is malignant fibrous histiocytoma. This is the heterogeneous group of aggressive soft tissue sarcomas. Age group usually 50 to 70 years of the males are affected. Location, musculature of the lower and the upper extremities and the retroperitoneum. Usually metastasis incidence is 30 to 50% to the lung and regional lymph nodes. Now this is the gross specimen showing the malignant fibrous histiocytoma or the MFH, which is multilobulated, unencapsulated, firm to fleshy mass, approximately 5 to 10 centimeter in diameter. On cut section, there is a gray white and the mixed white. On microscopy, here there are the spindle shaped pleomorphic cells forming storiform pattern histiocyte like round cells, bizarre multinucleated cells, frequent mitosis, lymphocytes and plasma cells. Different variants of the MFH is storiform or the pleomorphic, then myxoid, then inflammatory, giant cell, and the angiomatoid. These tumors of the skeletal muscles, rhabdomyoma, these are usually rare, benign soft tissue tumors located in the head, neck, tongue, larynx, and the pharynx. Types depending upon the degree of resemblance of the tumor cells to the normal muscle cells, adult and the fetal. Fetal rhabdomyoma. Here, the large round to oval cells with abundant granular eosinophilic cytoplasm and contain the glycogen cross striation in some cells. Then rhabdomyosarcoma. Here the commonest soft tissue tumor in children and the young adults, highly malignant tumor arising from the rhabdomyoblast. What are the different types? Embryonal, botryoid, alveolar, and the pleomorphic. Embryonal rhabdomyosarcoma, most common of the rhabdomyosarcoma. Commonest soft tissue tumor in children under 12 years of the age group and the young adults. Common location: head, neck, orbit, urogenital tract, and the retroperitoneum. This is the microscopic view of the embryonal rhabdomyosarcoma. Here, the small round to oval cells and some spindle-shaped cells with tapering ends, cytoplasmic processes frequent mitosis, with frequent mitosis here, the and broad fascicles and the bands, broad fascicles and the band. Then botryoid, here variant of embryonal rhabdomyosarcoma, age group children under the age group of 10 years, usually located in the vagina, urinary bladder, nasopharynx, and the bile duct. This is the gross specimen showing the distinctive grape-like gelatinous mass protruding from the hollow cavity. This is the vaginal opening, and here the mass is protruding from this. This is also the grape-like architectures. Now, botryoid rhabdomyosarcoma showing the microscopic view. There is a submucosal zone of hypercellularity, that is the cambium layer. And there is a rhabdomyoblast, visible cross striations, predominance of small round cells on the myxoid background. Next is alveolar rhabdomyosarcoma. Age group usually older children, young adults below 20 years, location usually the extremities. This is the alveolar rhabdomyosarcoma, gross specimen showing arising directly from the skeletal muscles, rapidly growing soft tissue and the gelatinous mass. This is the microscopic view of the alveolar rhabdomyosarcoma showing fibrocollagenous septae. These are the septae forming alveolar pattern in small cell with associated with frequent mitotic activity. There will be presence of tumor giant cells, demonstration of the cross striation in 25% of the cases. Next is pleomorphic rhabdomyosarcoma, less frequent variety. Age older adult above 40 years of the age group, usually located in the lower extremities. Here is a microscopic view. These are the highly anaplastic cells with bizarre in appearance. There is a numerous multinucleated giant cells, various shapes of the cell, strap cells, ribbon shaped with several nuclei, demonstration of cross striation by PTAH stain. Now, the tumors of the smooth muscle, usually first in the commonest tumor is the leiomyoma. It is the benign smooth muscle tumor located in the uterus most commonly. Then after erector pili muscle in the skin, nipple, scrotum, labia less often, in deep erector muscle or the pilar leiomyoma. It is pilar leiomyoma. Age group adolescent and the early adult. This is the gross specimen showing the subserosal leiomyoma in the uterus. So this is intramural leiomyoma. This is submucosal leiomyoma. Here are the bulging of white whorled trabeculated firm appearance of the leiomyoma. This is microscopic view showing the cigar shaped blunt-ended nuclei, which is benign cells. What are the complications of the leiomyoma? Common with larger and the long-standing tumors. There will be degenerative changes, that is tumor overgrowth, its blood supply, sometimes associated with the pressure symptoms, sometimes hyaline change, mucoid change, calcification, and the fatty change also seen. Complication of the uterine leiomyomas, first is red degeneration. It is commonly seen in pregnant women. There is a beefy red appearance in old tumor, may be accompanied by the pain and the fever. Next is leiomyosarcoma. It is a malignant version of the leiomyoma. Account 10 to 20% of the soft tissue sarcomas. Adult and the females are most commonly affected. Located in skin, deep soft tissues of the extremities and the retroperitoneum. Recur after its removal. Distant metastasis to the lung, liver, bone, and the brain. This is the gross specimen of the leiomyosarcoma showing the bulky, diffuse, soft to fleshy mass. This is the microscopic view of the leiomyosarcoma showing world arrangement of the spindle-shaped hyperchromatic cells, usually more than 10 mitosis per 10 HPF with or without atypia, or the 5 to 10 mitosis per HPF with atypia. Now, next tumor is vessel tumor or the vascular tumor, that is hemangioma. And the hemangiomas are usually two types. One is capillary hemangioma and second is cavernous hemangioma. Most common is the capillary hemangioma, usually located in the skin, subcutaneous tissues, mucous membrane of the oral cavity and the leaf. Less common in liver, spleen, and the kidney, and it regress spontaneously. That is the characteristic feature of the capillary hemangioma. Now, next part is cavernous hemangioma, usually located in the skin, faces, neck, other in the mucosa of the oral cavity, stomach, small intestine, internal viscera, liver, and the spleen. There is a no spontaneous secretion in cavernous hemangioma. So this is the gross picture of the cavernous hemangioma, and this is the capillary hemangioma. This is the cavernous, cave-like or slit-like spaces showing, and this is the capillary hemangioma showing the plump endothelial cells, walled blood vessels. Next is hemangioendothelioma. This is a true intermediate grade tumor of the endothelial cells located in the skin, subcutaneous tissues in relation to the small, medium, and the large sized vein. These are the well-defined gray red mass. Microscopic view of the hemangioendothelioma, there is active proliferation of the endothelial cells, forming layers around the blood vessels. Reticulin stain represent the cell proliferation in inner basement membrane. This is the gross specimen of the hemangiopericytoma. Uncommon tumor arises from the pericytes. This is the microscopic view showing small ovoid spindle-shaped cells with ill-defined boundaries. There is a collapsed blood vessels are arranged in stagon pattern. Sometimes it is stained with reticulin stain for confirmation to distinguish from the hemangioendothelioma. Next malignant tumor is angiosarcoma. This is malignant vascular tumor, also known as hemangiosarcoma or the malignant hemangioendothelium. Located usually skin and the subcutaneous tissue, liver, spleen, bone, and the retroperitoneum. Hepatic angiosarcoma is associated with the carcinogen arsenic polyvinyl chloride radioactive contrast. Distant metastasis seen in lungs and the other organs. Angiosarcomas are usually poorly defined margin with bulky firm mass with areas of hemorrhage and the necrosis. This is the microscopic view showing the vascular channels containing the red cells with prominent atypical cells with hyperchromatic nuclei. Then next class is nerve sheath tumors. Benigns are the schwannoma and the neurofibroma, and malignants are the neurofibrosarcoma and MPNST, that is malignant peripheral nerve sheath tumors, usually originate from the Schwann cells. First is schwannoma. These are the solitary nodules on the sheeted peripheral nerve, encapsulated solid. Multiple schwannomas occur in von Recklinghausen's disease in children. Microscopically shows the Antony A hypercellular area, dense compact cellular bodies, world pattern, parasitic body, auricular body. Antony B is hypocellular area. Hypocellular areas. Loose cellular area. Then neurofibroma. These are the multiple neurofibromas occur in von Reckling-Hansen's disease. Nodules of varying size along the cutaneous nerves, usually unencapsulated tumor protruding, producing enlargement of the nerves. Then neurofibroma usually on microscopy shows the bundles and interlacing fascicles of the elongated spindle-shaped cells with wavy nuclei, loose collagen of the mucoid areas, then locally recurrence 30% chances of malignant transformation. This is MPNST, also known as malignant schwannoma or the neurofibrosarcoma. Half of them are RSS gene over rest of them nerves involved by the Reckling-Hans disease. Usually located in the neck, forearm, then lower arm, limb, buttocks, grossly fusiform expansion of the nerves and foci of necrosis and the hemorrhage. This is the microscopic view of MPNST, there is a serpentine-shaped tumor cells, deep hyperchromatic nuclei with pale cytoplasm, palisaded or the whorled pattern. There is abundant mitosis, perivascular concentration, metablastic, 15% of the bones, and muscle locally recurrence and distant metastases are frequent. Next is synovial sarcoma, also called as malignant synovioma, distant soft tissue sarcoma. It is originated from the previously thought to be the synovial tissue, but it is from the multipotent mesenchymal cells. Age group is 20 to 40 years of the age, location around the knee and the thigh. Uncommon sites are parapharyngeal regions and the abdominal wall. This is the gross showing slow growing painful mass encapsulated on cut section, fish flesh like areas of hemorrhage and the necrosis, and there is a cystic species. Microscopy, there is a gland like architecture lined by the cuboidal to columnar cells. Here, the spindle cells forming the interlacing bands, infrequent mitosis, and stroma is mixed. Right? Next is alveolar soft part sarcoma. These are usually slow-growing malignant tumor of the uncertain histiogenesis. Usual age group is children, young adult, can occur at any age group sometimes. It is located deep tissues of the extremities along the musculofacial planes with skeletal muscles. This is the gross specimen showing the well-demarcated, firm, and usually located within the skeletal muscle. This is the muscle part and this is the tumor. This is the microscopic view showing the large tumor cells with abundant eosinophilic granular cytoplasm, diastase resistant pass positive, separated by fibrovascular septae of the alveolar pattern. Thank you. These all are the soft tissue tumors.